Welcome to MedEd's production of Inpatient Obstetric Certification Exam Review. My name is Jeffrey Fouche, and the title of this module is Antepartum Assessment. This module will cover antepartum assessment testing, including ultrasound and fetal monitoring capabilities. So we're going to talk about antepartum fetal assessment. These are some of the tests that we're going to talk about. We're going to go through each of these individually, but we're going to be talking about ultrasonography, non-stress tests, biophysical profile, amniotic fluid index, or AFI, modified biophysical profile, fetal movement counts, contraction stress test, fetal lung maturity, amniocentesis, chorionic-villus sampling, CORDOCENTESIS, and maternal serum screening. So we'll start with ultrasonography. And ultrasonography is just the use of high-frequency sound waves. It is the most common diagnostic procedure used during pregnancy, and it's used to produce images of the fetus, placenta, and the pelvic organs. It's used to date the pregnancy, to identify anatomy of the fetus, to examine the placenta, and to examine the amniotic fluid. The scans that are done in the early first trimester are very accurate as far as dating goes. They're also used to assist with other diagnostic procedures like amniocentesis. We know that some of the ways that ultrasonography works is that different structures produce different echoes that are returned to the machine and interpreted by the software and displayed as images to the user. Echoes from stationary tissues are the same from pulse to pulse, and that's how we know that they're stationary. Whereas echoes from moving objects exhibit slight differences in the time for the signal to be returned to the receiver, and so the software interprets that as movement and displays it as such to the user. Talk about the number and timing of ultrasounds during pregnancy. There's no set number, but typically you're going to see 2 to 3 scans are done during pregnancy. The first scan is usually done around 7 weeks, and that's to confirm the pregnancy, to exclude ectopic or molar pregnancies, and to confirm cardiac pulsation and measure the crown rump length for dating purposes. Sometimes an additional scan will be done around 18 to 20 weeks, and that's done to look for congenital malformations, to exclude multiple pregnancies, and to verify dates and growth as well as placental position. And then sometimes an additional ultrasound will be performed around 34 weeks, and that's done to evaluate fetal size and assess fetal growth and to verify fetal position. Early ultrasound is an ultrasound that's done in the first part of the first trimester. By 4.5 weeks of gestation, the gestational sac can be visualized, and by 5 weeks you can see the yolk sac. And by 5.5 weeks, the embryo itself can be visualized and measured. By 7 weeks, 6 to 7 weeks, you're able to actually detect fetal heartbeat and blood flow in the fetal blood vessels. A fetal crown rump length measurement done between 7 and 13 weeks gestation gives us the most accurate estimation of gestational age. We also will do biparietal diameters after 13 weeks and femur length at 14 weeks. So using ultrasound to help date the pregnancy, some of the measurements include, you'll see CRL, and that's the crown rump length, and that's just the length of the embryo from the crown to the rump. It's done in the early first trimester, and its accuracy is within 4 to 7 days. Biparietal diameter, head circumference, abdominal circumference, and femur length are all done after that time period. Up to 22 weeks, the accuracy is within a week. As you get closer to 30 weeks, the accuracy decreases to about 2 weeks, plus or minus. And after 30 weeks, measurements can be off by as much as 2 to 3 weeks, either less or more than the actual date of the pregnancy. So you can see why those early scans done in that early first trimester are the most important, because they're the most accurate. We also do ultrasound to monitor fetal growth and to obtain an estimated fetal weight. We usually do these if the fundal height starts to lag or exceed the estimated gestational age by their established due date. The accuracy of these scans, however, are low, particularly for the estimated fetal weight. In studies, only 70% of studies were accurate within 10% of the actual body weight. So that's a large percentage of scans that are more than 10% off from the estimated fetal weight and the actual weight of the fetus. We also will do a head circumference abdominal circumference ratio, and if that ratio is increased, that's a good predictor of intrauterine fetal growth restriction versus just a small baby where the ratio is not increased. And we'll talk about that when we talk about IUFGR later. The best approach is to do a combination of scans, clinical assessment, and analysis of risk factors. Unlike X-rays, ultrasound involves only sound waves. There's no radiation danger to the mom or the embryo and fetus. However, sound waves can increase body temperature in a process known as cavitation. We think it's only significant if we're talking about very prolonged exposure times. There have been multiple studies that have looked at the use of ultrasound and any damage to the embryo or the fetus, and they've shown no increased risk of cancer, low birth weight, dyslexia, or any delayed speech development in the baby. A non-stress test. A reactive non-stress test will have 2 accelerations within a 20-minute period during a maximum of 40 minutes of testing with a normal baseline and moderate variability. So in this example here you see this fetus is showing normal baseline, moderate variability, and there are 2 accelerations present in this time frame. Sometimes, as you know, the fetus is not always reactive right away when we put them on the monitor. So one thing we can do during antepartum testing is to do vibroacoustic stimulation or fetal acoustic stimulation testing. And that's where you apply a sound stimulus to the mom's abdomen for 3 seconds, and then we see if the baby responds to that. A reactive acceleration correlates with a non-acidemic fetus. So that tells us, gives us very good information that if we have accelerations, the fetus is not in any acidemia at the time that we're doing the testing. However, if there's no response to that, so if we do the sound stimulus and we do not get an acceleration, only about half of those fetuses were actually acidemic. So it's not a very good test to tell us who's acidemic, but it's very good to tell us who's not. This does have a decreased effect in preterm fetuses because their neurological system is immature. And then once membranes are ruptured, the acoustic stimulation stimulator does not work quite as well either because sound waves travel better through water, and if the membranes are ruptured, there's decreased water there, so the sound waves do not travel as well. And then for each of these tests, you're going to see this statistic called the false negative mortality rate. And what that's telling us is, for this test, for the non-stress test, that false negative mortality rate is 3 to 8 tests per 1,000. What that means is if I had 1,000 reactive NSTs in a week, first of all, I'd be exhausted from doing that many NSTs in a week. But if I did 1,000 of them and they were all reactive, I would expect to still have 3 to 8 of those fetuses to die within that week's time frame after the test. So that's what that rate is. Every time you see that rate, we're talking about the number of, we had a test that was indicative of fetal well-being, and within a week's period, how many of those 1,000 would we expect to still have a fetal death? So for NST, that's 3 to 8. Scalp stimulation can also be done instead of acoustic stimulation to help rule out metabolic acidemia and a non-reactive strip or a pattern associated with acidemia. And to do that, you apply firm digital pressure to the scalp, and you should avoid the fontanelles, and you should do this between contractions. An acceleration, if you get an acceleration from that, it is still a good predictor of non-acidemic fetus at the time we observe it. And again, a lack of acceleration is a poor predictor of an acidemic fetus. So our NST results, so when we end up, we're going to have either reactive or non-reactive. If it's reactive, then the recommendation is that you follow up testing within a week. If we get a non-reactive NST, then we're either going to perform a biophysical profile or a contraction stress test. A contraction stress test, or a CST, is done when we cause contractions to occur. We want to get at least 3 contractions in a 10-minute period. And then we look to see how the fetus responds to those contractions. And we can either do the contractions through giving mom exogenous oxytocin, so hooking her up to an IV and starting an oxytocin drip, or some protocols have the mom do nipple stimulation so she can have a release of endogenous oxytocin to get the contractions that we need as well. The false negative mortality rate for this test, for the CST, is 0.4 per 1,000. So you can see it's got a much better statistic attached to it when we do a CST. But as you can imagine, CSTs are very labor intensive and they're very difficult to achieve. When we do a CST, we're going to have one of 4 possible results. In this case, we're looking for a negative result, and that means there are no late decelerations present during the tracing. A positive CST means that there were late decelerations with at least half of the contractions that we observed in the tracing. Suspicious would be a CST where you have intermittent lates, which means you have late decelerations with less than half the contractions, or if you have variable decelerations during the testing period. Unsatisfactory, which is usually the most common result we used to get when we did these more commonly, is a result of poor tracing, so you couldn't trace the fetus well enough to maintain a continuous tracing, or you weren't able to get those 3 contractions in 10 minutes in order to meet the criteria for the test. So if we have a reactive negative CST, that means the NST was reactive, the CST was negative, we would just repeat that in a week. If we had a non-reactive negative, meaning that our NST was non-reactive and our CST was negative, we would need to repeat that in 24 hours. If we have a positive CST, we would either consider doing a biophysical profile or we would consider going ahead and delivering the baby. With a suspicious or unsatisfactory result, we would repeat testing in 24 hours. And because it's technically difficult and the length of the test is so long, most centers have moved away from doing CST to doing a biophysical profile or a modified biophysical profile. So biophysical profile is a test that consists of 5 different components. The first component is with the fetal monitor, and that's a non-stress test, and we've typically already done a non-stress test by the time we get to this point. The other 4 indicators are all done via ultrasound, and they include fetal breathing, fetal movement, fetal tone, and amniotic fluid volume. And be careful there, in this test we're talking about amniotic fluid volume, not an amniotic fluid index that we'll talk about later. And the biophysical profile has a false negative mortality rate of 0.7 to 2.29 deaths per 1,000. So far better than a non-stress test alone, but not quite as good as a contraction stress test. Here's how a biophysical profile is scored. And each component is you either get a 0 or a 2. So there's no partial credit. You can't get a 1 for anything. So if you ever get a result with an odd number, then you know someone did the results wrong. So it has to be an even number. And so we'll look at fetal breathing movements, and what they're going to look for on ultrasound is they want to see at least 1 or more episodes that last at least 30 seconds long within a 30-minute period. So they want to see those fetal breathing movements. If they do not see that, or the episode lasts less than 30 seconds, then the score is 0. Gross body movements, they're looking for 3 or more distinct body movements or limb movements within that 30-minute period. And episodes of active continuous movement count as a single movement. So if they have less than 3, then the score is going to be 0. Then they look at fetal tone, and there they're looking for 1 or more episodes of active extension with return to flexion. So they're looking for the baby to either extend and flex an arm, a leg, his spine. They also consider if they see the fetus opening and closing his hand, that would be considered normal tone as well. Reactive fetal heart rate, that's an NST that we probably already performed. You get 2 points for a reactive NST, 0 for a non-reactive. And then the last component is a qualitative AFV, amniotic fluid volume. And here they're looking for one or more pockets of fluid that measure at least 2 centimeters in the vertical axis. And so they're not going to do the whole abdominal cavity like they would with an AFI. They're just looking for that one pocket that's at least 2 centimeters. And the biophysical profile is based on fetal physiology. Each parameter of the biophysical profile is regulated by the fetal central nervous system. Parameters that develop first in life are the last to disappear with fetal asphyxia. Non-reactive NSTs and fetal breathing are the first 2 parameters that will deteriorate in a compromised fetus because they are the last parameters to develop in the fetus. We typically expect a fetus to be able to have a reactive NST by 28 to 32 weeks, and fetal breathing movements are present at about 20 to 21 weeks. Fetal movement deteriorates next because fetuses begin moving at about 9 weeks gestation, and fetal tone is the last parameter to disappear because fetal tone is present from about 7 to 8 weeks of gestation. So when we get our score results, here's how we interpret them and what our follow-up is. And remember, the ultrasound is going to give you a report of a score out of 8. And so when you report to your provider, you need to go ahead and add on your NST results as well. And so that's why the score will be out of 10 for the overall biophysical profile. So if we have 8 out of 10 or 10 out of 10, that indicates a normal interpretation and that there's a low risk for chronic asphyxia, and we should repeat the testing weekly or twice weekly depending on the condition. A score of 4 out of 10 or 6 out of 10 indicates suspected chronic asphyxia. If you're greater than 36 weeks, then we deliver, else we repeat that in 4 to 6 hours. If our score is 0 out of 10 or 2 out of 10, that's considered an abnormal result, strongly suspicious for chronic asphyxia, and the recommendation is that we deliver. An amniotic fluid index is an ultrasound measurement where the abdomen is kind of divided into 4 quadrants, and the ultrasonographer is looking at those 4 quadrants and determining the largest pocket of amniotic fluid that they can visualize. They then add up those 4 measurements, and that's how we get our score. It's either recorded in centimeters or millimeters depending on the software in the machine, and normal at term is considered 6.8 to 19.6, although most people use that, they round that up and say 7 to 20. Although cutoff values for oligo and polyhydramnios vary by gestational age, and so if the fetus is not termed, they'll look and see if it's below the 5th percentile for oligo or above the 95th percentile for polyhydramnios. The AFI is also based on fetal physiology. We know that if a fetus becomes hypoxic, he's going to try to spare his head, heart, and adrenal glands. And so with chronic hypoxia, the kidneys are poorly perfused, which leads to decreased urine output. And fetal urine is the primary component of amniotic fluid. And so decreased amniotic fluid is a strong predictor of fetal intolerance to labor. A decreased AFI is an indicator of the chronicity of fetal compromise, except for in type 1 diabetics, and I'll talk about that in just a second. The reason it's a good indicator of chronic fetal compromise is that it takes about 13 days for an AFI to go from normal to oligohydramnios. And the reason we can't use that as well for type 1 diabetics is just like with the mom tends to have polyuria, which is making a lot of urine. The fetus does the same thing, and so our values would not be as reliable in those patients. Here's an example of doing AFI calculations. And you can see the sonographer did 4 different images, one from each of the 4 quadrants of the maternal abdomen. And you can see the little plus signs on the images there, and that's the electronic calipers, and they're measuring the pockets of amniotic fluid. And fluid appears black on the ultrasound because the sound waves are not reflected back. And so then they went through quadrant 1, 2, 3, and then in the lower right corner you see they were trying to do that last quadrant, and there's stuff in there, and that stuff is actually the umbilical cord, and so they can't count that quadrant. But in this particular case, when they added up the other 3 quadrants, we still ended up with a normal score, and so this result was interpreted as normal. Some places will do a modified biophysical profile, and that's where you combine a non-stress test with an AFI. The non-stress test tells us about our present fetal condition, and the AFI is an indicator of long-term conditions. It's done because it's usually quicker and easier to perform than a full biophysical profile, and it has similar outcomes as a biophysical profile. We consider a modified biophysical profile to be normal if the NST is reactive and the AFI is at least 5 centimeters. And the modified biophysical profile has a false negative mortality rate of 0.8 deaths per 1,000. So it's a very good test to do to help let us know how well the fetus is doing, because we're getting a look at the here and now, so the NST, and then an AFI kind of looks backwards in time and tells us how well the fetus has been oxygenated over the last 2 weeks. A very simple antepartum test that can be done by the woman herself at home are fetal movement counts, or kick counts. These are an indirect indicator of fetal well-being, and even though most centers will have a certain number they tell a woman to measure, there's no evidence to support a specific threshold, but the most common one that people use is that she should feel 10 movements in a 2-hour period. She should be instructed to notify her provider if she feels that her fetal movements are decreased from normal, and certainly if there are less than 10 of those in a 2-hour period. Umbilical artery Doppler VELOCIMETRY, or Doppler flow studies, is done using an ultrasound, and what they're doing there is they're measuring the velocity or the speed of blood flow through the umbilical artery. And during systole, we should see a nice peak, because our blood flow should be very rapid during systole, and during diastole we should expect a downward slope as the blood flow decreases, but even during diastole we still expect there to be blood flow across the umbilical artery. So here's some graphical representations of what these would look like. In the top picture, that's a normal result. Blood is continuing to flow during diastole. You can see as the blood volume peaks up during systole, we have that downward slope during diastole, but never does it go all the way back down to 0. So it's staying up above the 0 line even during diastole. The second picture is taken from a fetus with increased vascular resistance, and that's where our blood flow is decreased. We may see that in moms who are preeclamptic or diabetic. What we see there is, even though we still have blood flow during diastole, the peak and the trough of that systole and diastole are much lower than they are in a normal fetus. So we've got decreased blood flow. The third picture is absent end-diastolic flow, and what that indicates is there's no blood flow during diastole. And so you can see in that picture we have the peak from the systole, and then during diastole it comes all the way down to the 0 line. And so when diastole is over, there's no blood flow going across the umbilical artery. And then the worst case scenario is reversed end diastolic flow, and that's where blood flow actually flows backwards into the fetus during diastole. And you can see in that picture the peak goes up. During diastole we slope down, and then you see those little hash marks there below the 0 line, and that's where it's measuring blood flowing backwards. And so that's kind of like, think about 2 steps forward, 1 step back, 2 steps forward, 1 step back. So that fetus is going to have decreased oxygen and nutrient delivery. An amniocentesis can be done anytime after 15 weeks, and that is a procedure where the physician takes a small spinal needle, inserts it transabdominally, and collects a sample of the amniotic fluid using the ultrasound to guide them. So they use the ultrasound to help visualize where they're going. They can either take the sample to be used for genetic testing or assessment of fetal lung maturity or other testing that may be necessary. It can also be done to reduce the amount of amniotic fluid with a polyhydramnios. So you may hear them talk about doing a reduction amniocentesis, and that's where they're just going to drain excess fluid off in a mom with severe polyhydramnios. Chorionicvillus sampling, or CVS, is where we obtain a sample of placental villi by inserting a catheter transcervically into the uterus at about 10 to 13 weeks. A sample is then collected for genetic testing, and it can be done before an amnio is considered safe, so it can be done earlier than an amnio. And there is a small risk of fetal injury and death from doing that, so the patient gets counseled on those risk factors. Cordocentesis, sometimes it's also referred to as PUBS, or percutaneous umbilical cord blood sampling, and it's similar to an amniocentesis, except for the umbilical vein is punctured and a blood vessel, a blood sample is obtained from the umbilical vein. It's used to test for genetic disorders as well as blood disorders, and it's this test has largely been replaced by doing a placental biopsy, which is similar to a chorionicvillus sampling, but is done transabdominally. So instead of inserting the catheter through the cervix, they usually use ultrasound, and they will go in and they will do a small biopsy of the placental tissue itself. There is a small risk of fetal death associated with this, and the most common complication is bleeding at the puncture site, which they have ways to control that. Some more antepartum testing would be fetal pulmonary maturation, and this usually requires an amnio to be done because they're going to collect amniotic fluid. And there's a couple different tests that they may run. There's the fetal lung maturity, or FLM. Sometimes you'll see that referred to as TDX. That was a brand name that was used at one time. And it's a very rapid, inexpensive test with highly reliable results. And that's usually the first test that they will do. So if that comes back mature, then you're reasonably assured that the fetal lungs are mature. If it comes back immature, they may do an LS ratio. And that's just two different types of substances that are present in the amniotic fluid. And if that LS ratio is mature, so if that comes back greater than or equal to 2, then we consider that to be a mature result, and those results are very reliable, even though the FLM may have come back immature. And occasionally they will do an additional test along with the LS ratio, and that's the PG levels. And that just increases the reliability if our test is mature. So if we get a mature LS ratio and a PG level that's mature, then it's a very strong indicator, almost within a very high degree of certainty that the fetal lungs are mature. The other reason they may do a PG level is if there's reason to believe there's blood or meconium in the amniotic fluid. Those can alter the LS ratio, but they do not alter the PG levels. We also test antepartally for genetic diseases, and those include different types of chromosomal abnormalities. We know that there's some type of chromosomal aberration in about 1 out of every 160 newborns. And most of those have no effects, and we don't even notice them. They only show up when people have testing later in life for other reasons. There are sex chromosome aberrations, and the sex chromosome aberrations that you may see are monosomy, which of course means there's one copy of it. So monosomy X, and you'll see that sometimes as 45X, and that's called Turner syndrome. And that occurs in about 1 out of every 10,000 live births. These patients are phenotypically female, and they will have dysfunctional ovaries, and they're prone to a long list of chronic diseases later in life. Klinefelter syndrome, which is 47XXY, or you can have 48XXXY, depending on how many copies of the X chromosome there are, occurs in about 1 out of every 1,000 live births. These patients are phenotypically male. They'll have small testes. They'll usually not be able to produce any sperm, and they typically will have language and communication problems later in childhood. Trisomy X, which is 47XXX, occurs in about 1 out of every 800 live births, and those patients are phenotypically female, and is typically undiagnosed. This is usually found out later in life from other, when someone has to be tested for other reasons. Trisomy Y would be a 47XYY, so that's an extra copy of the Y chromosome. So these patients are phenotypically male. Occurs in 1 out of every 1,000 live births. There's usually normal sexual development, but we do see more rates of learning and language delays and behavioral and emotional difficulties in people with this particular chromosomal aberration. We can also have autosomal trisomies, and so now we're not talking about the sex chromosomes, we're talking about the autosomal chromosomes. We can have trisomy 21, and that's Down syndrome. It's the most common autosomal chromosomal syndrome that we see. It occurs in 1 out of every 800 live births and usually results in mental retardation and facial abnormalities. Trisomy 13 is FETAL syndrome. It's really rare. It only occurs in 1 out of every 20,000 live births, but it has a very high mortality rate. By 1 month of age, half of all babies born with FETAL syndrome die, and by 1 year the mortality rate is 80%. They tend to have very severe neuro and cardiac anomalies, and that's usually the cause of death. Trisomy 18, or Edwards syndrome, occurs in about 1 out of every 8,000 live births. The median lifespan is about 5 to 15 days, so these babies do not live long at all. They tend to have very severe heart, kidney, and internal organ abnormalities. We also will do first trimester genetic screening to detect the risk of trisomy 21. Some of the tests we may do include ultrasound measurement of nuchal translucency. And what that is they're measuring a pocket of tissue in the fetal neck. We can also do maternal serum measurements, and you usually hear that referred to as a triple test or quad test. And they're looking at PAP-A, free beta HCG, and what we know is there's an increase in neural tube defects. If the nuchal translucency is increased, if there's a decreased level of PAP-A and an increased level of HCG, that combination is predictive of trisomy 21. Here's a slide showing what nuchal translucency looks like, so you can see the fetus there, and near the bottom of the slide you can see the two little calipers again, and that's measuring that nuchal translucency. So it's looking at that amount of tissue there between the outer layer of skin and that inner layer there. So that's what they're looking for with nuchal translucency. We can also do second trimester genetic screening. That's also used to detect trisomy 21. We can also detect trisomy 18 and neural tube defects. The most common test is the quad screen, and that includes alpha-fetoprotein, or AFP, HCG, unconjugated estriol, and inhibin A. And the combinations that we'll see is in trisomy 21, or Down syndrome, the AFP and the unconjugated estriol levels will be decreased, and the HCG and the inhibin A levels will be increased. In trisomy 18, we'll have a decreased level of AFP, unconjugated estriol, and HCG. And if the AFP level is increased, that's an indicator of neural tube defects. And so what they'll typically do is these patients will then, the mom will be offered to have an amniocentesis done to help confirm any diagnosis. We also offer genetic screening for other conditions based upon family history or based upon ethnicity, even without family history. Some examples would be we now offer genetic testing for all ethnic groups for cystic fibrosis. But some particular ethnic groups are at increased risk for other diseases, so we tend to do targeted genetic screening for these groups. Patients who have a black ethnicity are at increased risk for having sickle cell, so they'll typically offer genetic testing for that. Ashkenazi Jews are at increased risk for Tay-Sachs syndrome, Canavan and Canavan disease, and so they'll be offered testing for those. Patients from a Cajun or French Canadian ethnicity background are at increased risk for Tay-Sachs disease, and patients from Mediterranean or Southeast Asia cultures and ethnicities are at increased risk for the thalassemias. That's the end of this module.